Good morning, everyone. Thank you very much for joining us, especially on the last day of an outstanding meeting. I'd like to welcome all our participants on the West Coast, early as it is, and in Europe already in the afternoon. The session this morning is on sensory disease and aging. It's an excellent follow-up to the sessions we heard just previously on cognitive dysfunction in HIV, and yesterday on falls. Sensory problems in aging are very, very important contributors that we don't often think about as potential contributors to cognitive decline and functional status. And so we have two excellent presentations this morning on aspects of sensory function. The first one will be by Dr. Douglas Jabs, and he will be not be able to join us afterwards live for the Q&A, but he'll be the first presenter. Dr. Jabs from Johns Hopkins University. He's a clinician scientist and expert in uveitis. He's got a long track record in clinical trials, translational research. His work focuses on performing clinical trials in uveitis and developing best practice guidelines for the management of these conditions, especially in regards to their long-term outcomes. He has served as the chair of numerous NIH-funded, multi-center, international, national effective trials, as well as long-term prospective cohort studies. He has co-authored over 320 peer-reviewed journal articles, as well as numerous book chapters. So we welcome Dr. Jabs.
Thank you very much for inviting me to speak today. These are my financial disclosures, none of which are relevant to this talk. The most common age-related eye diseases are cataract, glaucoma, and age-related macular degeneration. Cataract is the most common, but is relatively easily treated with cataract surgery, which has an over 95% success rate. Conversely, AMD is a much more difficult disease to manage. Age-related macular degeneration is the leading cause of loss of vision and blindness in patients over 65. It's the third leading cause of loss of vision worldwide, and it's very expensive to treat. In 2010, the cost of treating neovascular age-related macular degeneration was about 10% of the Medicare Part B drug cost. Age-related macular degeneration is staged, and the estimated US prevalence of intermediate stage age-related macular degeneration, or AMD for short, is about 8 million people. And of the more severe stages, neovascular AMD and geographic atrophy, about 1 million people each. One can see on the graphs on the right that the prevalence rises with age of both AMD in general and late-stage AMD, and that it is higher among Caucasian Americans than among African Americans. Here are the stages of AMD. This is intermediate stage, multiple small drusen here or here, plus pigment changes. Drusen are composed of lipoproteins, complement, and immunoglobulin. Late stage AMD is what causes visual loss, either from the formation of new blood vessels, as we can see here with bleeding underneath the macula, or geographic atrophy, as we can see here, where the central area that one would see well with is damaged and lost. The import of intermediate stage AMD is that once you have it, you're at high risk for progression to late stage AMD. Now, we know from some work that we've done using the longitudinal study of the ocular complications of AIDS, that patients with AIDS have a slight excess of cataract over other cohort studies using similar methodology, particularly at younger ages. We also are able to evaluate the retinal vascular using semi-automated methods to evaluate the caliber of the central retinal arteries and veins as they emerge from the disc, and converting them to measurements called the central retinal artery equivalent and central retinal vein equivalent. Both of these decrease with age, and when we compare patients with AIDS to patients who are HIV uninfected, we find that they have vascular calibers that are about similar to those between 11 and 24 years older there, again, suggesting some accelerated or accentuated aging in patients with AIDS. Now, the study I'm going to talk about is the longitudinal study of the ocular complications of AIDS. It was a prospective observational cohort study started in 1998. Enrollment finished in 2011 and follow-up in 2013. All patients had AIDS. They were recruited throughout the United States with and without ocular infections and with a wide range of CD4 T cells. They were given a detailed medical history with chart confirmation of all diagnoses, routine laboratory testing, and of course, IRB approval and written consent. Retinal photographs were taken on about 99% of the cohort participants at enrollment. There were 2,392 participants, of whom 535 had ocular infections, and one cannot evaluate the retina for age-related macular degeneration in the presence of an infection that causes extensive retinal damage. 32 patients had no photographs. So the study population was 1,825 persons with AIDS. We also had 5- and 10-year follow-up retinal photographs, and they were all graded at a centralized reading center by graders unaware of the clinical findings of the patients. A standardized system was used to grade the photographs for grading for age-related macular degeneration, and the primary outcome was intermediate stage AMD. This was chosen because it's more common, about tenfold more common than late-stage AMD, and also because there are some data to suggest that nucleoside reverse transcriptase inhibitors may interfere with the development of retinal neovascularization. After we evaluated both the prevalence and incidence of AMD in the cohort, we compared them to HIV uninfected cohorts, which use similar methodologies. This is the characteristic of the 1,825 patients in the study as a whole. Relatively young, mean age of 43, overwhelmingly men, mix of races. Patients had had AIDS for, on average, 4.3 years. Of note, approximately half of the patients were current or former smokers. Antiretroviral therapy at or prior to enrollment was highly common, 94%, and as one we'll see in the follow-up study, over 99% used it during follow-up. Median CD4 T cell count at enrollment was about 200, with a wide range, as one can see, from the 25th to 35th percentile. It's important to note that this was a cohort where there had been profound immune compromise at some point in the past. The median nadir CD4 T cell count was 44, again with the 25th to 75th percentile of 13 to 113. About 20% were co-infected with HCV. This is the prevalence study of AMD at baseline. Overall, about 10% of patients had AMD, and as one can see, the prevalence increases with age, as one would expect. Smoking was a risk factor for AMD, and it's a risk factor in HIV uninfected people as well. An unexplained observation is that in patients with injection drug use and patients where the HIV risk group was heterosexual transmission appear to have a higher risk of AMD than those from other risk groups. Diabetes, hypertension, and cardiovascular disease all were associated with AMD, as they are all age-related diseases. Things that were unassociated are shown on the left. Specifically, antiretroviral therapy was unassociated, and if anything, the rate of AMD was lower in those who received antiretroviral therapy. No specific drug was associated with AMD. Also, enrollment CD4, nadir CD4, enrollment HIV, maximum HIV prior to enrollment, and hepatitis C all were unaffected, unassociated with AMD. In the multiple regression of risk factors, age was associated prevalent AMD, injection drug use and heterosexual transmission remained associated, and current smokers appeared to have an excess risk of AMD, again, consistent with what we see in HIV uninfected populations. Now, we were able to compare our prevalence of AMD with the Beaver Dam offspring study. This study used the same reading center and the same methodology. And when one does an age and gender adjusted prevalence, one can see that there is approximately a 4.1-fold increased prevalence of AMD in persons with AIDS versus an HIV uninfected population. The next study was to evaluate the follow-up photographs. As one can see, we had of the 1825 who had neither opportunistic infections and had baseline photos, about 189 had AMD and were not available for evaluation of incident AMD. The numbers you can see here show those who died with less than 5 years of follow-up, those who were enrolled too late to have 5 years of follow-up, and those who were lost to follow-up, resulting in a study population of approximately 730 patients. The mean age of this population is similar to that of the 1825 in the prevalence study, with similar risk factors. Again, smoking, approximately 60% were current or former smokers, with similar use of ART, including 99% using it during follow-up, similar CD4 plus T cells and HIV loads, and about 20% with HCV co-infection. These are the risk factors for incident AMD. The rates are greater based upon greater baseline age, although this is not significant. The Cox regression shows that current and former smokers both had an increased risk of AMD. We were able to compare our incidence of AMD with the multi-ethnic study of atherosclerosis. Again, this was a group that used the same reading center and the same methodologies. And one can see that the two groups had different baseline age. The MESA study had an older age. We were unable to do age adjustment in this comparison, but we were able to gender and race adjust. And despite the older age group in the MESA study, patients in ELSOCA had a 1.75-fold increase incidence of AMD with an adjusted incidence of close to 1% per 100 person years. Sorry, 1 per 100 person years. So we know that patients with AIDS have an increased prevalence of AMD and an increased incidence of AMD. This finding is consistent with the accelerated, accentuated aging phenotype seen in ART-treated, immunorestored HIV-infected persons. Smoking is a significant risk factor for AMD, as it is in HIV-uninfected persons. It's not related to antiretroviral therapy, HIV load, or CD4 T cells. And we know that there are some markers of systemic inflammation in HIV-uninfected persons that appear to be associated with AMD. And therefore, we looked in our population for whether or not systemic inflammation was associated with AMD in patients with AIDS. We performed a case control study of participants with AMD versus those without, using two controls for each case matched by decade of age, gender, and race and ethnicity. We had cryopreserved baseline plasma specimens, and we assayed them for biomarkers using immunoassay kits. Plasma biomarker concentrations were log base 10 transformed in order to get a normal distribution, and then standardized to standard deviation units because of the different dynamic ranges, and quartiles were compared. We looked at mortality as an outcome, and hazard ratios are adjusted for HIV load, CD4 T cells, and the biomarkers. These are the biomarkers we evaluated, including C-reactive protein, IL-6, IP10, soluble CD14, soluble CD163, KT ratio, and IFABP. And you can see the inflammatory role that they play in this table. This is the baseline characteristics of the study population. You can see that we were reasonably well matched on age, gender, AIDS-defining illness, and the use of antiretroviral therapy. There were no significant differences in HIV load, CD4 T cell counts, or CD8 T cell counts at baseline. Now, AMD is associated with mortality in our population, and one can see a 48% increased risk of mortality if a patient has AMD at baseline. These are the baseline results of the biomarkers, and only IL-6 has a suggestion of being associated with AMD. However, several of the plasma biomarkers are also associated with mortality. One can see here in the graphs that CRP, IL-6, soluble CD14 all appear to be associated with AMD. And here are the hazard ratios of these, whether one looks by comparison per quartile or the fourth versus the first quartile. And those are significantly associated with AMD, with mortality rather. We did a multiple Cox regression of mortality for AIDS, and in the multiple regression, AMD ceased to be associated with mortality. HIV load and CD4 T cells were not surprisingly associated with mortality. So we looked at what happened. And in the multiple Cox regression, CRP, IL-6, and IP-10 remained associated with mortality. So we did a stepwise variable selection of mortality on AMD in patients with AIDS. And one can see AMD alone, again, at 48% excess mortality. But as one stepwise adds the biomarkers, this association is lost. Conversely, HIV and CD4 do not make as big a difference in the association with mortality as do the biomarkers. These data suggest that intermediate stage AMD is associated with increased mortality in patients with AIDS, that the plasma inflammatory biomarkers are associated with mortality, which we know is present in both HIV infected and HIV uninfected aging. And the AMD association with mortality was attenuated in the multiple Cox regression by the inflammatory biomarkers, suggesting that that AMD mortality and systemic inflammation are all related. We know from study in patients who are HIV uninfected that late stage AMD, especially neovascular AMD, is associated with mortality, but intermediate stage AMD is not associated with mortality in the HIV uninfected. Therefore, this suggests that there is an intensified phenotype in patients with AIDS. Finally, AMD takes a long time to develop, years to decades. So it might be unreasonable to expect an association of biomarkers with prevalent AMD, given that it is a one-time evaluation. We've begun to look at the association of baseline biomarkers with incident AMD. And as one can see here, CRP, IL-6, and soluble CD14 all appear to be associated with incident AMD in our preliminary data. Again, suggesting that there is a strong relationship between systemic inflammation and the aging eye, or at least in AMD in this group. The conclusions of our work are that there is an increased prevalence and incidence of AMD in patients with AIDS. This is consistent with the accelerated and accentuated aging phenotype seen in patients who are ART treated and immunorestored and HIV infected. There's an increased mortality in AIDS of persons with AMD, which appears to be associated with systemic inflammation rather. Systemic inflammation appears to be a risk factor for incident AMD. The limitation of this work is that the population is a population of patients with AIDS, not with earlier stages of HIV, and is a population that has seen low CD4 T cell counts prior to enrollment in the cohort. And so one needs to be careful about generalizing it to earlier stages of HIV, as we do not have data in that group from this cohort. I want to thank you very much for inviting me to speak and for your attention to my talk. These are my funding, without which this could not have been done, and this work could not have been done. Thank you.
Thank you very much, Dr. Jabs. I'd like to remind all the attendees that unfortunately we will not be able to take any questions for Dr. Jabs, but we will be able to, and I encourage you to ask questions of Dr. Ellis, our next presenter. We just heard an excellent talk on some of the ocular complications, and now we're going to hear from Dr. Ellis about problems with peripheral neuropathy. Dr. Ellis is a physician scientist whose lab and clinical work looks to define how pathological interactions between HIV and the host result in neurological disorders, including dementia, as well as peripheral neuropathy. These interactions are revealed in part by studies of human RNA and other markers in the CSF. Dr. Ellis and his colleagues at the UC San Diego HIV Neurobehavioral Research Program hope to design interventions to better treat and prevent neurocognitive complications of HIV. Welcome, Dr. Ellis.
Thanks to the organizers for giving me this opportunity to present some of our work on neuropathy and neuropathic pain. Very quickly, I'm going to go through some definitions of those two phenomena, how we diagnose them, briefly review historical aspects and what has evolved over time with changes in antiretroviral therapy, briefly go over the pathogenesis of neuropathy, talk about the current burden and clinical impact of the condition and the contribution of the brain to processing pain, and finally, how we manage pain and the potential for neuroregenerative treatment to improve peripheral nerve function. So we diagnose peripheral neuropathy as a set of findings on examination. This consists of symmetrical, distal, more than proximal involvement of sensory function with reductions in sharp, temperature, vibratory sensation, and position sensation. Sensory is typically involved to a much greater extent than motor, and there is typically loss of distal reflexes, particularly the ankle jerk. What patients pay attention to is the symptoms rather than the signs of neuropathy. So when they come to clinical attention, it's mostly because they have burning or stabbing pain. They report pain from normally non-painful stimuli. Some things as simple as the bed covers touching the feet are very uncomfortable. They can also report distal numbness and paresthesias, which are less bothersome, and rarely mild distal weakness. And what you see in that histogram is that 40% of patients with the findings of neuropathy on examination don't report any symptoms. And we know this from research studies where we systematically ask them about symptoms. So you see in the Venn diagram some, but not complete overlap between the presence of symptoms and the exam findings. Stimulated skin wrinkling is an interesting potential diagnostic abnormality, which I will just briefly mention because it's kind of an interesting phenomenon. So all of you are familiar with the fact that when you spend a lot of time in the water, you'll start to see some skin wrinkling, which is displayed here on the left-hand side. And that is actually an active phenomenon, not just a passive waterlogging of the skin. And it has to do with activation of sympathetic small fibers in the skin that retract some of the connective tissue. We also use skin biopsies to characterize epidermal nerve fiber density. You can see in the lower panel here, in a normal skin biopsy, using PGP 9.5, we visualize clearly very distal ends of small nerve fibers, unmyelinated, extending up into the dermis and epidermis. And in the context of neuropathy, the fibers are lost, and there are these abnormal excrescences where the fibers end in bulges rather than free nerve endings. Of the 1.1 million people in the US with HIV, about over 600,000 are estimated, projecting from our research findings, to have findings of sensory neuropathy. And of those, about 100,000 have moderate to severe neuropathic pain. People with distal sensory polyneuropathy in the pre-CART era, so before combination antiretroviral therapy, the risk factors were increasing age, current use of antiretroviral therapy, past use of D drugs, and a lower CD4 nadir and a history of opioid abuse and dependence. And I'll come back to this later because that picture has changed quite a bit. Having neuropathic pain is associated with a very significant reduction in quality of life, both physical and mental health, and also with a variety of other complications, including major depressive disorder, lack of employment, and becoming dependent in activities of daily living. The neuropathogenesis involves two major changes. One is infiltration of activated macrophages into the dorsal root ganglia where the sensory neurons live. And the second is abnormal mitochondria and mitochondrial function that we believe to be induced both by HIV proteins such as TAT and also by antiretroviral therapy, and much more likely with the older drugs that are no longer used. We've come to realize that distal nerves are not static structures. They're highly dynamic. They're influenced by a variety of trophic and toxic factors, and the balance between these two is what determines the configuration of the sensory neuron and its fibers. The major evolutions in the treatment and disease landscape in HIV are the availability of these new antiretroviral regimens that are more potent, more convenient, more tolerable, and have markedly reduced neurotoxic potential. At the same time, the burden of diabetes and other metabolic conditions that represent risk factors for neuropathy has increased. So we've got these two countervailing forces. And so we did a study to look at the evolution of distal sensory polyneuropathy and distal neuropathic pain over 2 years and identify risk factors for new onset or worsening of these conditions. Cutting to the bottom line, over 250 individuals followed for 12 years, 50% of them virally suppressed. We saw neuropathy prevalence increase from 26% to 44%. Incident, so new onset DNP, neuropathic pain occurred in 42. Those who didn't have it at baseline, and of those who did have it at baseline, 29% worsened. On the left here, you can see the risk factors for incident neuropathy signs. I'll look at symptoms in a moment, but the main ones are older age, increased height, which we've known for quite a long time now. Taller people are more likely to show DSP signs on exam. And then the presence of distal neuropathic pain is also a risk factor for incident neuropathy. On the left-hand side, the risk factors for neuropathic pain advancing age, a higher body mass index, so obesity is a risk factor for worsening neuropathic pain, and not being employed is another risk factor. So employment actually is protective. People with neuropathic pain have a markedly reduced quality of life, as we mentioned previously. So that association has continued. And so in conclusion, even though we have better antiretrovirals that are less toxic, we continue to see an increase in these neuropathy conditions. However, it's important to remember that many older people with HIV remain free of these conditions. And we'd really like to know what are the factors associated with absence of these conditions, because this may give us a clue as to potential treatment abnormalities. Notably, the factors that have been associated with incident pain and neuropathy are quite different from the early CART eras. So previously, exposure to D drugs, CD4 nadir, and viral suppression, none of those things is any longer a significant predictor. And now it looks like body mass index, obesity is a predictor, and employment was protective. We think that it may be a surrogate for unmeasured health factors such as socioeconomics and regular exercise. So given these developments, it's time to re-examine how we treat this condition. And at the end, I'll talk about a couple of novel therapeutic approaches. One more important reality of the clinical impact of neuropathy is this marked increase in fall risk or balance disturbances. As you know, falls are a major source of morbidity in people with HIV and in the general population. And although neuropathy does not seem to be noticeably predictive of balance problems in the non-HIV population, in people with HIV, it's a highly significant risk factor. And this is based on a study of almost 3,400 participants. The brain has a major impact on the clinical phenotype of neuropathic pain. This is largely, the substrate is the dopaminergic projections, particularly the mesolimbic projections and mesocortical projections that innervate the cortex and structures like the nucleus accumbens projecting from the midbrain. This dopaminergic system has been studied in great detail in normal individuals. And what we found is that a genetic variant strongly predicts or associates with pain perception. So a common variant in the catechol O-methyltransferase gene, which this variant is associated with reduced enzymatic activity, leading to higher synaptic dopamine levels. And these people have much greater pain perception, lower pain thresholds. And this can be indexed by opioid activity in the nucleus accumbens, which is regulated by dopaminergic system. We looked at this same COMT variant in our people with neuropathic pain. So we hypothesized that this would be a moderator of the relationship between signs of neuropathy on exam and the clinical phenotype of neuropathic pain. And in over 1,000 participants, as you can see in this multivariable analysis, the MET variant was associated with a markedly increased risk of having neuropathic pain. So this variant affects the clinical phenotype. Another source of the central nervous system modification of pain processing is the default mode network, which is a network of brain structures that in which activity is temporally linked. These structures including the medial prefrontal cortex, the cingulate gyrus, and the inferior parietal cortex. So when a person is essentially daydreaming, this system becomes active. My colleague John Keltner has done studies in which he showed that individuals who experienced neuropathic pain had smaller posterior cingulate cortex, the posterior cingulate being one of the components of this default mode network. And preliminary data from functional MRIs also show that blood flow changes are associated with pain expectation in people who have neuropathic pain. The overall interpretation of all these data is that this mind-wandering default mode network is a mechanism actually to distract the brain, if you will, from painful stimuli. And the characteristic of people who experience pain is that they have a reduced activation in this network. Just a few words about treatment. We are highly motivated to seek alternative effective treatments for the neuropathic pain, because we now have this as a lifelong disease, as you saw, contributes to polypharmacy, often incomplete response to analgesics, even opioid medications, and other adjunctive neuropathic drugs. These are some of the drugs that we use. They are moderately effective, but as I mentioned, there are many treatment resistant individuals. One of the less well-known interventions is this high-dosed capsaicin, which is must be administered in a doctor's office with pre-treatment with opioids, because it's a very painful treatment, but a single treatment results in a marked reduction of those epidermal nerve fibers that I showed you earlier, and typically up to 3 months of pain relief from just a single application. So a very, very interesting and promising new pain intervention strategy. Another intervention that we are spending a lot of time focusing on is the endocannabinoid system, which can be manipulated using exogenous cannabinoids like cannabidiol and THC. The receptors for these endocannabinoids are highly represented in brain structures that are important for pain perception. And a large number of studies have shown significant benefit in terms of neuropathic pain on administration of cannabis. These are principally very short-term studies because historically it's been these required inpatient treatment because of restrictions, legal restrictions. We were unable to send people home with the drug. But at least in short term, it shows considerable efficacy, and long term, lots of anecdotal evidence. Finally, I'll mention one of the novel pathophysiological insights So I told you that there are a variety of trophic and toxic factors that influence the balance between sensory neuronal health and degeneration. And it recently was discovered that an M1 antagonists enhance neurite outgrowth. So in other words, neurons are constitutively under the influence, a negative influence of muscarinic receptors on their neurite outgrowth, and by blocking those receptors, you can enhance neurite outgrowth. And diabetic neuropathy has been studied, looking at the intraepidermal nerve fiber density that I showed you earlier on skin biopsy, and these topical antagonists have been shown to be effective in restoring nerve fiber density and have very little systemic side effects because they're administered topically. So that ends my presentation. I thank you very much for your attention and I hope this was interesting.
It's very, very stimulating, very thorough review with some very interesting novel presentations. We have quite a few very provocative questions. I think it's going to stimulate a very interesting discussion. So all of these are for Dr. Ellis. Is the sign of DSP the absence of stimulated skin wrinkling?
Yes. So, and specifically, this is small fiber neuropathy, where you see the absence of the stimulated skin wrinkling.
Okay. Are DNP and DSP really different? Isn't DSP a symptom of DSP?
That's correct. Occasionally, we do see patients, though, who have typical pain syndrome, you know, the distal symmetrical tingling, burning, stabbing sensations, but in whom we get normal reflexes. One of the findings of the recent study was that pain appeared to be a harbinger of later increased risk of developing signs of neuropathy. And if we do very detailed nerve studies using more sensitive methodologies, we essentially always are able to pick up evidence of nerve degeneration or injury in people who report that kind of pain, even though they have normal physical neurological examinations.
Okay. Your finding about employment as a factor generated a number of questions. Is employment protective, or does DSP-DNP lead to reduced employment? That was coupled with, does it protect from depression, which could also be a confounder in these conditions?
So really good questions. The first one has to do with, well, what's the temporal relationship between the two? And at a cross-sectional assessment, yes, having neuropathic pain is associated with being unemployed. The interesting thing we found was that being employed at baseline predicted lower risk of subsequently developing neuropathic pain. So the direction does not just seem to be, well, you get pain and you become unemployed. Again, I think it's probably a surrogate. The second question has slipped my mind. Could you just repeat that?
The second question had to do with depression.
Oh, depression. Yes. So yes, unemployed people are more likely to be depressed. Depressed people are more likely to report neuropathic pain. When we've looked at the two, I didn't show these data, but when we've looked at the two in multivariable models, they do have independent relationships to neuropathic pain.
If I may just add a question on this particular topic between unemployment and depression. Is there a link with drug use, which can then also contribute in addition to mood disorders?
It's a good question. And many people with a history of substance use disorders are not able to be employed. I haven't looked at it, so something for me to do in the future.
So staying in the area of drug use, do younger individuals in their 20s who use injection heroin have legacy on increased neuropathy and pain, which may increase downstream many years later after stopping drug use? Is there any evidence for that?
Yeah, again, I didn't show these data here, but we did a previous study in which we found that people with a history of opioid dependence were more likely to have developed neuropathic pain. The causality of that association isn't clear, but I think it's a real association. We didn't examine the question in quite the way or examine that issue in quite the way that the question was framed, looking at, drug abuse at a young age and then things, quote unquote, catching up with you, a legacy effect later on. But that's something that could also be examined.
Thank you. And staying in the area of predisposing protective factors or risk factors, a question asked, can you interpret what seems like a strong protective association between being African American and experience of neuropathic pain in your data? Is it possible that the comp variant varies along racial ethnic lines in your sample?
It does. I am not remembering the direction, but there's a clear effect of genetic ancestry on the prevalence of that variant. And there's a somewhat attenuated association between the variant and neuropathic pain, depending on African versus European ancestry.
Thank you. And a question about a little bit asking for more information about use of the MR antagonist. And are there any specific ones that you could refer to, please?
Yes. So one is actually already available. It's a topical formulation of oxybutinin called Gelneek, and it's marketed for the treatment of stress incontinence. Again, it's a topical application. And that is actually the formulation that was used in the study by Arthur Vinnick that I mentioned in the last slide. There is a newer agent available. It's much more selective for M1. So we are planning to study that drug. It's called brenzapine. By the way, I didn't mention it, but the major impact of this in terms of outcomes that can be measured is regrowth of the epidermal nerve fiber layer. Now, I had a concern when I first heard about this. Well, wouldn't that possibly increase pain because you're now waking up dying nerve fibers? That doesn't appear to be the case, at least in the oxybutinin study. But it's something that we will be looking at carefully. Are we benefiting nerves at the risk of increasing pain, or are we going to have a positive hit on both accounts?
If I may just jump in with my own question about use of oxybutynin analogs, we know in the geriatric population that these are the drugs have potential toxicity and may lead to confusion, may lead to falls, etc. Is that a potential concern in younger patients who may be using these drugs for an extended period of time given the chronic nature of this condition?
Yes, that's a very important issue. The drugs are CNS active when administered systemically. The advantage here is the topical administration, which avoids high concentrations exposure to the brain.
So, in other words, there would be probably very little systemic absorption, even with prolonged use.
Correct.
That's very encouraging. Another question was interesting area. Yeah.
You're cutting out, Julian.
Go ahead, please. Oh, I'm sorry. The question was, is DNP different from fibromyalgia?
Yes, many people with fibromyalgia have normal neurologic examinations. In fact, the majority do. They are overlapping in a number of ways. However, for example, this COMT variant is a risk factor for fibromyalgia. And some of the same brain regions that I showed you in the last few slides that are involved in pain processing overlap between neuropathic pain and fibromyalgia. So there are a lot of interesting areas of overlap, not entirely clear why, but brain pain networks are ancient and probably were co-opted to serve functions other than their original simple pain perception and avoidance behaviors, and became involved in a variety of other systems. And so when they're affected, they affect a host of different behaviors and syndromes.
Thank you. Questioner asked, do you use capsaicin in people with persons with HIV with a history of injection drug use or heroin use?
I have not experienced any problem with that. I should mention that the drug is only FDA approved for the treatment of zoster-related neuralgia, herpetic neuralgia. It is not approved for the treatment of HIV distal neuropathic pain, although it is often used off-label for that purpose. I've had pretty good luck in getting people treated at my site. We have to run them through our pain service. But many people do find it quite effective, and I've not heard any reports that it's contraindicated in people with a history of opioid abuse.
If I may ask a question, please. Given the association between diabetes, obviously, and peripheral neuropathy, can you comment, or is there any information on the association between insulin resistance and neuropathy, particularly in HIV, where both conditions are more common than in the general population?
Absolutely. I've not actually looked at insulin resistance. I have seen reports that elevated hemoglobin A1C levels in the absence of a diagnosis of diabetes are associated with neuropathy and neuropathic pain. But I've not seen specifically other measures of insulin resistance. So that would be something interesting to be taken advantage of in the future, and a potentially treatable condition.
Okay, thank you very much. Are there other questions that people would like to send in? If not, then I think we'll close the session. I'd like to thank Dr. Ellis and Dr. Jabs for outstanding presentations on two very important aspects of sensory dysfunction in aging, and as it pertains to HIV individuals, where it can contribute to important aspects of impairment in quality of life and overall function. hopefully in upcoming years, we'll be able to hear more about some of these sensory issues, specifically auditory impairment and smell, which are the other major areas of sensory impairment, which can also affect HIV. We'd like to thank the participants and for the excellent questions. And I think now we'll be having a short break and we'll be able to catch up. Thank you very much.